Welcome back to another video, you guys. For my returning viewers, you're welcome. And for those who'll be watching for the first time, please stay tuned for amazing content on how to pass your NCLEX exams. And please make sure to like this video, subscribe, and comment down below. Turn on your post notification bell button as well, because that will enable you to see when I post new content. And if you didn't know yet, this channel, for the moment though, because I'm going to do other things as time goes on, but this channel for the moment is about the content that you need for your NCLEX exams. NCLEX has two parts, okay? The critical thinking part and the content. So you need to know your content to be able to apply critical thinking on answering the questions. You wouldn't just go ahead and answer questions on something that you have no idea on. You'll be guessing. You might be lucky to guess and pass, but it's even more easier and more stressless if you can only know your content before you go into that exam. And we know that there's so many things you need to know as content is concerned. But I'm just giving out the things that you have to know and you must know to be able to ace your NCLEX. Because all the questions will be centered around this same things, asking you the same questions in different ways. And they'll be centered around the content that I'm reaching out to you. I don't know how else to, convince you guys to watch this channel and watch these videos and, learn something out of it. But a few of you who have actually watched came back and made some comments that made me to come back to do the videos and continue doing the videos, because when I uploaded the first two content, I didn't get that many reactions, which of course I'm creating it for you guys, and if you guys do not really benefit anything from it, so what's the need? So I was just like, okay, let me take a deep breath and rest, relax myself. Of course, after all, I'm done with mine, so what is the benefit? So I just was like, maybe it's not even necessary. And then a few of you came back to me and was like, please keep doing content, we enjoy your session and things like that. So I'm doing this for those who actually know what they're looking for and know that they need to know this content for the NCLEX. So without further ado, let's get started. But please do not forget to hit the subscribe button, like, share this video to other nurses who are struggling with the NCLEX, and let me know what you think in the comment section. Okay, so last time we ended at we did obstetrics, and that was so good because we learned a lot of things. So in today's video, we will continue with maternity and obstetrics as well. Please, these are things that you need to know. It doesn't even take that long. Just stick around, pick the things that you need to pick out of these lectures, and go use it to ace your NCLEX. Trust me when I say these things will be there in one way or the other, okay? So let's get started. Maternity and obstetrics. The first thing we're going to talk about under this is pregnancy and how to calculate due date. I believe most of you already know this little content, but let me just, go over it again. How to calculate due date. So to calculate a woman's due date, you take the first day of the last menstrual cycle or the last menstrual period, okay? The first day of her last menstrual period, okay? When you take that first day, add 7 days to it and then subtract 3 months. What did I say? The first day of her last menstrual period, add 7 days and subtract 3 months. That will give you her due date, okay? So they will always trick you with two dates. They will give you the day she started menstruating, and they will give you the day she stopped menstruating. just to trick you and confuse you. But do not get into that trap. Don't fall into that trap. Look for the first day that her menses started. That first day, add 7 days to it and subtract 3 months. Please don't fall in that trap of taking the last day of her menstrual period. Take the first day, add 7 days, subtract 3 months. You're good to go with due date. All right. Okay. Weight gain in pregnancy. Remember, we're talking of pregnancy. We've looked at due date. Now we're talking of weight gain. All right. In this case, we'll be talking of a typical pregnancy. We're not going to be talking of a pregnancy, a woman who is obese or underweight. We are looking at a typical pregnancy because NCLEX or the board, they look at a typical ward. They're not looking at, those other side things happening. No, they look at a typical ward. And when I say typical ward, we are looking at a typical pregnancy. All right. When I say typical again, I'm trying to refer to the woman is normal weight. All right. So we are looking at a typical pregnancy and how to calculate weight gain. So the thing you need to know is that in the first trimester, second trimester, or let me say it in weeks. Okay. In the first trimester, she gains 1 pound each month. First trimester, the woman will gain 1 pound each month. So the first trimester is 3 months, right? So the woman will gain 3 pounds in the first trimester. And then in the second trimester and the third trimester, she will gain 1 pound each week. 1 pound each week. Do not be confused. I said in the first trimester, she gains 1 pound each month. And the first trimester is how many months? 3 months. So she will gain 3 pounds for those 3 months. Sorry, guys. So she'll gain 3 pounds for the first 3 months, which is the first trimester. And then the second and the third trimester, she'll be gaining 1 pound each week. But if they give you a question, you will not even have that time to begin to count, okay, this woman is at weeks 28, so let me count the first trimester is 12 weeks, and then the second trimester, third trimester. You will not have that time. So here is a shortcut on how to do that. So whenever they give you a question asking for weight gain in pregnancy, there is an ideal formula. So what you do is you take the weeks of gestation minus 9. Weeks of gestation minus 9. Okay, I wish I had a board to be showing you guys in writing. So weeks of gestation minus 9. What does that mean? This is how they'll ask you. They'll be like, a woman is 28 weeks pregnant and she gained, let's say, 10 pounds. What do you think? That's how they'll ask you. What do you think? So if a woman is 28 weeks pregnant, how many pounds is she normally supposed to have gained? That will be your first question to ask yourself. If a woman is 28 weeks pregnant, how many pounds is she normally supposed to have gained? So use the formula that I gave you. The formula says you take the weeks of gestation minus 9. She's 28 weeks minus 9. You'll be at what? 19, right? Okay, so at 28 weeks gestation, she is supposed to have gained 19 pounds. But the question says she gained 10 pounds. So, is that normal for her weeks of gestation? Of course not. You get it? So that's how they will ask you. And then, if she is supposed to gain 19 pounds and she has gained 10, what are you supposed to be thinking about as a nurse? You'll be like, oh, nutrition. Maybe something is wrong at that level. Maybe she's not feeling well. Okay? So that's how they will ask you the question. They're not just going to ask you to calculate some numbers. If you're fortunate, they might just ask you to calculate, but most of the times they'll not go straight like that. They'll be like, a woman is 30 weeks pregnant, she has gained 40 pounds. What do you think? The first thing you have to do is you have to know how to calculate the normal weight gain in pregnancy. And if you're able to calculate the weight that she was normally supposed to gain at the 40 weeks gestation, then you'll be able to know what the weight was supposed to be. And if it's less than that or more than that, you begin to think, oh, something might be wrong somewhere. I don't know if you got that point, but the ideal weight gain calculation in pregnancy is just take the weeks of gestation minus 9. They'll give you the weeks of gestation in the question, minus 9 from it, and then you see the weight that she's supposed to have gained in those weeks of gestation. And when you see that weight, compare it to the weight that is given you in the question. And if the weight that she has gained is less or more, you begin to know that, oh, this might have been the cause. Okay. And the next thing we will look at is fundal height. Fundal height. Oh, so you know the fundus is the top part of the uterus. And you need to know when we can palpate it. Okay. And this top part of the uterus is not palpable until weeks 12. So that's the end of the first trimester. That's when you begin to be able to palpate the fundus at weeks 12. And usually at this time, it's about just above the symphysis pubis in weeks 12. Okay? And it's at the belly button between weeks 20 to weeks 22. It will be at the belly button between weeks 20 to 22. Just stay tuned because I'm going to get into some really good shit. Sorry, oh my God. Some really good explanations as to why you need to know the fundal height, okay? Where it's supposed to be at what stage. So, why is it important to know the position of the fundus? This is because if you know the position of the fundus and at what weeks of gestation this woman is at, you'll be able to know the weeks of viability, because weeks of viability are between weeks 22 to 24. And you know what this means, right? Viability is like the time, that stage where if the child is taken out of the uterus, it could survive outside of the uterus. So this happens between weeks 22 to weeks 24. So if a woman comes to your clinic and she's unconscious, just by looking at the fundal height, you'll be able to guess at what stage she is in her pregnancy. That's the ideal thing they want you to know here. They want you to be able to know how to guess the weeks of pregnancy of someone who comes to your clinic unconscious, or some other things are happening and they don't even know when they were pregnant. They don't even know anything. Just by looking at the fundal height, you could be able to tell where they are at in their pregnancy. So if you can palpate the fundus just above the symphysis pubis, they are probably at weeks 12. And then if the fundus is at the belly button, they are probably between weeks 20 to 22. Okay? And then remember the age of viability, which is 22 to 24 weeks. Okay. So in the first trimester and the second trimester, the priority is the mother. And in the third trimester, the priority is the baby. So let's go to some other interesting things, signs of pregnancy. A lot of people always get this confused with, because, oh, the normal thing we know is that the signs of pregnancy are when you go take a pregnancy test, go see the doctor, do the blood pregnancy test, and then do the urine test and all that, missing a period. But I'm going to shock you, because those are not even the real signs of pregnancy. Those are the probable signs of pregnancy. So I'll group signs of pregnancy into two only, which is the positive and the maybe signs, okay? The positive signs of pregnancy, the first thing I want you to know before we get into them is that you, the woman who is pregnant, you can never tell that you are pregnant. Not like you can never tell. To consider your pregnancy a positive one, or to consider these signs as positive signs of pregnancy, they must come from an examiner, not from you, the pregnant woman. Okay? So, the first positive sign of pregnancy, there are four signs of positive signs of pregnancy. When I say positive signs of pregnancy, these are those signs that when you see them, then you are pregnant no matter what. Okay, and remember, these signs can only be told to you by an examiner, not by you yourself. So the very first one is fetal skeleton on x-ray. Fetal skeleton on x-ray. The second one is fetal presence on ultrasound. The third one is auscultation of a fetal heart, which occurs between weeks 8 and 12. Okay? And the last one is when the examiner palpates fetal movements. Fetal movements. What did I say? There are 4 positive signs of pregnancy. The first one is fetal skeleton on x-ray. The second one is fetal presence on ultrasound. The third one is auscultation of a fetal heart, which occurs between weeks 8 and 12. Even though the heart starts beating at weeks 5, around weeks 5, the heart of the fetus starts, beating at weeks 5, but it can only be palpated between weeks 8 and 12. So if an examiner auscultates the fetal heart, then you are pregnant. And the last one, when the examiner palpates fetal movement, then you are pregnant. Those are the positive signs of pregnancy. And anything out of this 4 that I just mentioned is a maybe sign. It's just something to say, oh, maybe I'm pregnant. So what are the maybe signs? All urine and blood pregnancy tests, all of the urine tests that you do at home, all of the blood pregnancy tests that your doctor will do for you, they are all considered as the maybe signs of pregnancy. Even if they are positive, they are not positive signs of pregnancy unless an examiner see the 4 things that I just listed above. All right? So remember, the maybe signs are all your urine tests, all your blood tests are the maybe signs. Even if the blood test or the urine test says positive, still you cannot conclude that you're pregnant yet. That's why it's called a maybe. So the second maybe sign is the Chadwick, the Gödel, and the Hager sign. These are all maybe signs. So what is the Chadwick? The Chadwick is the cervix changes color into blue, or your cervix becomes cyanose. That's Chadwick. So one of the maybe signs of pregnancy is the Chadwick sign, whereby the woman will see that her cervix has changed color into blue, cyanosis. And the Gödel is when the cervix softens, and the Hager is when the uterus softens. So it starts with the Chadwick, changing of the color to blue, and then the cervix will soften, and then the uterus will soften. So all this fall under one of the maybe signs. So there are 2 maybe signs, your urine and blood test, and this Chadwick, Gödel, and Hager signs. These are maybe signs. So if you ever see this anywhere in your questions, please do not pick them as positive signs of pregnancy. They're just the maybe signs. If an examiner was not involved to examine you and look at a fetal skeleton on x-ray and see a fetal presence on ultrasound and auscultate a fetal heart rate, and examiner also palpates the fetal movement, if these 4 things didn't happen, you are not pregnant according to the positive signs of pregnancy rule. So even if you get a positive urine and a positive blood test, And even if you see a Chadwick sign, a Godel sign, or a Hager sign, still you are under the maybe position. You're under the maybe signs of pregnancy. I hope you get that, because this will come in your exam in one way or the other. So, how do you teach a woman in pregnancy? You know, in pregnancy, they need to come in for checkups and all that. So, what do you tell them? So, you tell them that they should come in once a month until weeks 28. They need to come in for checkup once a month until weeks 28. So, if this is their first month of pregnancy or first week of pregnancy, they need to come in every 4 weeks, which is once a month, right? Every 4 weeks they will come in, every 4 weeks they will come in until weeks 28. And then from weeks 28 to weeks 36, they start coming in 2 times in a month. That's every 2 weeks. And then from weeks 37 down to the deliver, they have to come in once every week. Okay? So a question might come this way. They might ask you, a woman comes in for her 8 weeks checkup. When will all her next appointments be? They can ask you something like that. Even though that sounds a little bit really long to ask, but I'm just trying to make you understand how they might ask you questions in this area. And then we'll talk about hemoglobin in pregnancy. You'll see this a lot when it comes to like lab values, because they expect you to know the normal hemoglobin levels in a pregnant woman. Okay, so in the first and the third trimester, their hemoglobin level should be greater than 11. In the first and the third trimester, it should be greater than 11. In the second trimester, it should be greater than 10.5. All right? Just take note of those values because you see them. Okay, discomfort of pregnancy and how to help this woman. Remember, as a nurse, you are there to provide safe care, help these people. They need your help. So, in pregnancy, a woman will face certain discomforts. And these discomforts are like morning sickness, urinary incontinence, difficulties breathing, and back pain. You'll find difficulties like that in pregnancy. So let's go one after the other. Let's take morning sickness first. I want you to know that when they say morning sickness, it doesn't necessarily mean that it just have to happen in the morning. The name says morning sickness, but it doesn't just mean that it's going to happen in the morning. It can happen anytime within the day. But because it happens in majority of the women in the morning, they just call it morning sickness. So with morning sickness as a discomfort, what do you do to help this woman? Give her what? Dry carbs. Okay? Give her dry carbohydrates before she gets out of bed. So when she wakes up in the morning and still on her bed, nicely placed, just give her dry carbohydrates before she gets out of bed. If she gets out of bed and starts her day before you give her dry carbs, you've missed it all, because that will not help. Remember, these are discomfort and we're trying to help so that she shouldn't go through a lot it should help her reduce the level of her discomfort. So give her these dry carbs while she's still in bed before she steps out of bed. The second one is urinary incontinence. And this urinary incontinence, it happens in the first and the third trimester only. You should begin to think why it doesn't happen in the second trimester. So in the first trimester and the third trimester, the baby or the fetus is pressing on the bladder. Because if you look at the anatomy, you'll find that the bladder and the uterus is really close. They are really close together in such a way that if something is happening to the uterus, it can directly affect the bladder. Okay? So, when the uterus is becoming, bigger and bigger and bigger, in the first and the third trimester, it affects the bladder directly because it presses on the bladder and causes urinary incontinence. She'll just pee without even knowing, things like that. And in the third trimester also it causes that because in the third trimester this baby is trying to start to make its way out of the uterus, so it comes back down and then starts pressing on the bladder. But in the second trimester you do not suffer urinary incontinence because of course the pregnancy is in the abdomen. It's not right down there on the bladder, and so you do not suffer urinary incontinence in the second trimester of pregnancy. And what do you teach these women who suffer from urinary incontinence? Because remember, we're looking at discomfort and what we should do with this discomfort. And with urinary incontinence, what you should teach them is that they should try as much as possible to avoid at least 2 hours from the day of pregnancy till 6 weeks after delivery. Teach them to void every 2 hours. Every 2 hours. So if a woman comes to you and say, I suffer from this urinary incontinence, you should begin to think, oh, they should probably be in the first and the third trimester of their pregnancy. And what you teach them is tell them to void every 2 hours till 6 weeks after delivery. That will help them. And the third discomfort is difficulties breathing. You can begin to guess when it should happen, and it is a problem of the second trimester. Second and third trimester, difficulties breathing. Where does this happen? In the second and the third trimester, this pregnancy, especially the second, is in the abdomen and it affects your diaphragm, so you will suffer from difficulties breathing. So it's a second and a third trimester problem. So what do you teach these women? You teach them the tripod position. So they'll put their hands on their knees and lean forward. This position, you find COPD patients equally assuming it because it helps with breathing issues. And then the fourth discomfort of pregnancy is back pain. Back pain happens in the second and the third trimester. So you treat it by teaching them pelvic tilt exercises and teach them to tilt the pelvic forward, okay? So they'll put their foot on a stool and then tilt their pelvic forward. Pelvic tilt exercises. It helps with back pain. All right, labor and delivery again. Our sessions 2, we talked about labor and delivery, okay? But in this session, we will be talking about some of the things that we didn't talk about in the last session. So if you haven't watched that one, you have to watch it so that you can continue the knowledge as we go. All right. So we're going to look at the true most valid signs that a woman is in labor. So as a nurse, you're supposed to know. You're not just supposed to assume, and you're not just supposed to hear from her that I'm in labor and just assume that, yeah, they're in labor. As a nurse, you need to know how to know that a woman is in true labor. There are false labor alarms, so there should be true labor alarms as well. So you need to know the valid signs that she is in labor. And what is the sign? Onset of regular progressive contractions. Onset of regular progressive contractions. So if her contraction is not regular and it's not progressing, then she's not in true labor. You get that? So they will test you on this. They'll test you on how you should tell that a woman is in true labor. So remember, onset of regular progressive contractions. Okay? Okay, let's look at some terminologies. Dilation. Dilation is opening of the cervix and it goes from 0 until 10 centimeters. We should know this already. When your cervix is closed, it's at 0 centimeter, and then it starts to dilate until it fully opens up at 10 centimeters, which is when the woman can, push plus other things. put together. Effacement is the second terminology. Effacement is thinning of cervix, and it goes from thick to 100% effaced. So the labor starts with a zero dilation of the cervix and a thick cervix, and then it goes to 10 centimeters dilated or fully dilated to 100% effaced, which means it's completely thin. Your cervix is thick and then gets thinner and thinner and thinner until it gets to 100% thin, or we call it 100% effaced. Okay? All right. Station. Station is the relationship of the future presenting part to the mom's ischial spines. That's the station, the relationship of the future presenting part to the mom's ischial spine. So where is the presenting part with respect to the ischial spines? And these ischial spines, they are the smallest or the narrowest part of the pelvis via which a baby should fit to be able to be born vaginally. What are they? They are the narrowest or the smallest. I always try to describe it like this, like they are the narrowest or the smallest part of the spine, of the pelvis, via which a baby can fit through to be born vaginally. So you should imagine the mom's ischial spines to be something like this, and then this is the head of the baby, or the presenting part, whatsoever the presenting part might be, hopefully the head, of course. Let's say this is the ischial spine, okay, and this is the presenting part. If the presenting part fits nicely into this mom's ischial spines, this baby can be born vaginally. But imagine that these are the ischial spines and my head is the presenting part. It doesn't fit. Then the baby cannot be born vaginally. So that is station, the relationship between the presenting part and the mother's ischial spines. Okay, you'll see negative station and positive station. When they talk of negative station, it just means that the baby is still really above the ischial spine. The presenting part is still above the ischial spine. And when you talk of positive station, of course, positive numbers equals to positive news. It means the baby's presenting part has actually come below the ischial spines. Okay. Let's look at another terminology, which is engagement. It's not the one that you know, okay? Engagement. Engagement means the station, the future part is at station 0, meaning the presenting part is at the ischial spine. Engage. You always hear them say, oh, the baby has engaged. That means the presenting part is at the ischial spine. That's good news, of course. And then another terminology we'll look at is the lie. L-I-E. That's the relationship between the spine of the mother and the spine of the baby. Okay, the way the spine of the mother is and the spine of the baby is, it constitutes what we call the lie. So we will look at vertical lie and transverse lie. So a vertical lie is when the baby's spine is actually in the same direction as the mom's spine. So this is a good, it's compatible because this baby can be born vaginally. Let me use my hand that this is the baby, okay, and this is the spine of the baby. All right, and the baby is presenting like this, and me, the mother, this is my spine. So we are at what? We are at a vertical line, so this baby can come down and be born vaginally. But if this is the spine of the mother and this is the spine of the baby, what have you seen? There's a transverse line going on here. This baby cannot be born vaginally. Okay. Presentation, it means the part of the baby that enters the birth canal first. Okay. And in this one, most common presentations you see is the right occiput anterior or the left occiput anterior, ROA or LOA. Let's go to another interesting subtopic, which are the 4 stages of labor and delivery, which we saw in our in the other video, the previous video. Okay, so I'm just going to go real quick here, and then I get to what the priority is in this part. Okay, stage 1 is all about labor, which we talked about in our previous video, so you can go back there, watch it, and then you see what we were talking about in stage 1, which is all about labor. And in this stage 1, you'll get to see how the future heart rate patterns are behaving, which is very important because they will always test you on that. So if I were you, I'll look at that video and know what the first stage of labor is all about. And in this first stage of labor, there are 3 phases which we will talk about in this video. Exciting. We'll talk about the 3 phases of the first stage of labor. Okay. And so the second stage of labor is all about delivery of the baby. Of course, you can check back at the other video. And delivery of the placenta is the third stage. And then the fourth stage is recovery, which is the first 2 hours after the delivery of the placenta. So you can look back at the previous video to be able to know really what we talked about in the stages of labor. But in this one, we're going to actually focus on the first stage of labor and the phases in the first stage of labor. Okay, that's the labor chart. All right. So I would like to throw light on some things here. The purpose of uterine contractions in the first stage of labor is to dilate and efface the cervix. The purpose of uterine contraction in the second stage of labor is, of course, to push the baby out. And then the purpose of uterine contractions in the third stage of labor is to do what? To push the placenta out. And the purpose of uterine contractions in the fourth stage of labor is to stop bleeding. Just try to remember those. Postpartum technically begins 2 hours after delivery of the placenta. Okay, postpartum. All right. Let's go into the meat and the potato of labor chart. Labor chart is all about the phases of labor and delivery, which happens in the first stage of labor. Okay, you need to know these phases. There's no way you shouldn't know them and expect to pass this obstetrics questions on the NCLEX. You need to know this labor chart. You need to. Why am I saying you need to? Because they will present to you a chart of contraction and future heart rate and things like that. And you need to know where they are at before you'll be able to answer the questions right. Okay, the phases in the labor chart, you will see 3 phases of labor. Okay, 3 phases in the labor chart. And remember, all these phases are happening in the first stage of labor. So the first phase, of course, is a latent phase. And here you need to know that the cervix dilates from 0 to 4 centimeters. 0 to 4 centimeters. And the contractions, they come every 5 to 30 minutes apart. They are like 5 to 30 minutes apart. And the duration of these contractions is 15 to 30 seconds only. And of course, it's of mild intensity. All right, you need to know this. In the latent phase of the first stage of labor, cervical dilatation is 0 to 4 centimeters. Your contractions are 5 to 30 minutes apart, which means if a contraction will come every 5 to 30 minutes. And it will last for like 15 to 30 seconds. So the pain of the contraction will last for like 15 to 30 seconds and it's gone. All right. So you need to know this and know that this happens in the latent phase of the first stage of labor. And there's something else you need to know about the latent phase of the first stage of labor. You need to know that in the latent phase of the first stage of labor, you should avoid at all costs, try to avoid giving pain medications at this stage, because remember, labor is just about starting. And then if you give opioids, pain medications unnecessarily, it's going to suppress this labor, because this woman is just starting. So if you give her opioids, pain medications, it might suppress these contractions, and it might suppress and delay her labor process. So avoid it. But if you must give her a pain medication in the latent phase, give it at the peak of the contraction. When the contraction is at its peak, you can administer it at that time. All right? Okay. We go to the active phase. Here, the dilatation is from 5 to 7 centimeters. So the cervical dilatation is from 5 to 7 centimeters. And the contractions are every 3 to 5 minutes. And they last 30 to 60 seconds. And of course, the intensity is moderate. So you need to know that the active phase of the first stage, sorry, you need to know that in the active phase of the first stage of labor, the cervix will dilate from 5 to 7 centimeters. The contractions are every 3 to 5 minutes, and the last 30 to 60 seconds. In the active stage or phase also, I want you to know that this is the phase where pain management is the priority, because here there is a lot of pain. So you have to manage pain in this stage, and that should be your priority in this at this level. Okay. Transitional phase is when the dilatation goes from 8 to 10 centimeters, and the contractions come every 2 to 3 minutes, and they last 60 to 90 seconds. So I want you to get something at this transition stage. It's very important to know that a contraction should not come before every 2 to 3 minutes, and the duration of the contraction should not exceed 90 seconds. If it exceeds 90 seconds and it's coming before every 2 to 3 minutes, that's telling you that this woman's uterus is over contracting, or that is uterine tachystoly. And when this is happening, you have to, if your oxytocin was going on, you need to stop it, because these contractions are going way too high and way too much. It can cause the placenta to separate from the endometrium when it's not yet time. So you have to try as much as possible to monitor these contractions and make sure that they do not come before every 2 to 3 minutes, and they do not last longer than 90 seconds. You'll see this a lot. Yeah. Okay. So one thing you should take away from this lecture on the labor chart is contractions should not be longer than 90 seconds or closer than every 2 minutes. Take that with you, because when you see questions, you will see that they will try to test you on this, because remember, you're going to practice as a safe nurse. So if you are sitting there and a woman is contracting and the contractions are before every 2 minutes, and the duration is lasting longer than 90 seconds, and you sit there as a safe nurse and you do not know this, you are going to put your patient in trouble and yourself in trouble. So you need to take home this with you, that contractions should not be longer than 90 seconds and shouldn't come before every 2 minutes. Okay? All right. So like I said, if a woman's contractions are longer than 90 seconds and closer than every 2 minutes, it means she's going through uterine hyperstimulation. or that those are signs of uterine tetany, or it could be um, oxytocin going on and you need to stop it. Okay. So frequency of contractions is the next thing we're going to look at. Frequency of contractions. Frequency is beginning of one contraction to the beginning of the next contraction. Duration is beginning to end of one contraction. Intensity is the strength of contraction, and it's purely subjective. I'm the one feeling it. You do not know what I'm feeling. So the intensity of my contraction is subjective, and you're not supposed to know how I'm feeling because I'm the one feeling it. So, complications of labor. Complications of labor. Yeah, the first complication of labor we'll talk about is painful back labor. Painful back labor. Do not confuse this with back pain as a discomfort of pregnancy. Remember, there's back pain, which is just a discomfort of pregnancy, but here we're talking of complications of pregnancy, and a complication is something that we didn't expect to happen. So the first complication is painful back labor. Painful back labor. So what do you do if this is happening to a woman in pregnancy under your care? You have to position her in the knee chest position, okay, and then you place a fist into the sacrum. Remember, it's a painful back labor, meaning she's laboring with her back, and it's so painful. I've never been there, but I can imagine the pain. So what you do is put her in a knee chest position and then make a fist and place it into her sacrum. That will relieve her of this pain. The second complication is prolapse cord. Please take note of these complications because you're going to see questions on this. The second one is prolapse cord. So this is when the cord is the presenting part. Okay, the cord comes out first. So imagine the cord is the presenting part. When you do your vagina examination, the cord is the presenting part. So what happens if the head is actually coming down? It will just bounce on that cord, compress it, and then this child will die because there will be no supply anymore. So prolapse cord is a complication, and this is an OB emergency. If ever you see that the cord of the baby is the presenting part, be careful. That's a big medical OB emergency. You need to do what? So what you need to do is you need to take her for CS because this is the only way that will help, and put her in a push position. Put her in a push position, and then you use maybe your gloved hand, and then you push on the head or whatever the other part is that is about to be explored. You push it back up so that it shouldn't press on the cord. All right, and then you take her for CS. Okay. That will be all about labor and delivery. So I'll encourage you to watch the previous video and this video so that you can wrap up your content on pregnancy, labor, obstetrics, and delivery. All of that put together. Watch the previous video, watch this one, and you're good to go with obstetrics. Okay? So please, again, share this content if you like it to other people who need to know some things about this to be able to help them pass their NCLEX. And like I said, every little thing that I'm teaching you guys here, you'll find it in the NCLEX in one way or the other, because I know what I'm saying. I've been there, and that's why I'm confident to bring this content to share with you guys. I'm confident about this content. I'm super confident, which is why I'm like, oh, I wish you guys could see through the eyes that I saw this content with and what it did for me. It really helped me. Try as much as you can to understand your content and then learn the critical thinking skills to be able to help you ace your NCLEX. Okay? Like this video, share it, subscribe, and please drop your comments. I like to see the comments. I like to know what you guys are thinking. And remember, turn on your post notification bell button because we still have a lot to talk about. Okay? And trust me, this content is interesting. We will talk about the endocrine system in our next video. Stay tuned and good luck.